اوكي، السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله سيدنا محمد عليه أشرف الصلاة وأتم التسليم. Thank you, Mr. Chairman, for the introduction. Thank you, the organizing committee, for the invitation. Today I'm going to talk about the update in gout arthritis. So we'll go through the acute management of gout, the lifestyle management, the comorbidity associated with gout, chronic management in gout, including the targeting therapy, the options that we have, and the indication of uric lowering therapy. For the acute management, as usually, we like to apply that we learn to the clinical practice. So this is a 43 years old male patient, known case of multiple cardiac comorbidity and chronic kidney disease, referred to rheumatology clinic with the left first big toe pain and right knee pain. Physical exams that showed arthritis of the first big toe and the right knee, and the aspiration confirmed the presence of monosodium urate crystals and confirming the diagnosis of gout. So what is the best treatment option for this patient acute flare? We'll go through 2020 SR guideline for the management, and just to highlight that the green color is going with strongly recommendation, the gray color conditionally recommended, the orange color going with conditionally against this recommendation, and the red color going with strongly against use this. So for acute management of gout, we have these options for treatment. We have the standard care, that colchicine, non-steroidal anti-inflammatory drug, and corticosteroid. And also we have the interleukin-1 inhibitors and synthetic ACTH. So the first recommendation that was to start with the standard care of therapy, including colchicine, non-steroidal anti-inflammatory drug, and steroid, over using interleukin-1 inhibitor or ACTH. The choice of the colchicine and NSAID and glucocorticoid was based on the patient preference, access, and the patient factors. And when we say the patient factors, we concentrate mainly, number one, the patient comorbidity. We concentrate here mainly on the kidney disease, stomach disease, and cardiac disease. Also, we need taking the consideration that presence of active infection during the therapy and previous history of allergic to any medication. And the third one, we have to consider the patient medication because of drug-drug interaction. And the best example for that we highlight this cyclosporin is contraindicated to use with the colchicine, as that will increase the cyclosporin toxicity. When using the colchicine, they prefer to use low dose of colchicine rather the high dose, and the high dose is defined by persistent hourly dose of colchicine until the resolution of the flare, while the low dose is not exceeding in the day 1.8 milligram. And for patients not tolerating orally, IV or IM or intraarticular glucocorticoid is preferred over the interleukin-1 inhibitor. For patient failing or contraindicated to standard care of therapy, I mean colchicine, prednisolone, and non-steroidal anti-inflammatory drug, so they prefer to use interleukin-1 inhibitors in form of anakinra or canakinumab. And conditionally recommend to use topical ice over the affected joint. So in the clinic, usually the patient, after the treatment, after he knows that he have gout, he will come to tell you what should I eat, what should to avoid. So this is the common burden we face in the clinic. So the recommendation come first for all the recommendation for lifestyle is conditionally recommended. We advise the patient to limit alcohol for non-Muslim patient, limit purine intake, and limit high fructose corn syrup. That means soft drinks mainly. And this cartoon, just to easily remember that alcohol, soft drinks, seafoods, and red meat with the liver. Against recommended to use vitamin C as a treatment for gout or as a urate lowering therapy. And for obese patient or overweight patient, we advise always for weight reduction. Whenever you have gout, whenever you diagnose gout, don't forget gout is apart from metabolic syndrome. We recommend to advise to screen all patients for metabolic syndrome, especially obese one, when you diagnose gout. And remember that our patient has multiple cardiac comorbidity, including diabetes, hypertension, dyslipidemia, and chronic kidney diseases. So for obese patient, I will start by the last slide that I mentioned, that we advise for overweight and obese patient for weight reduction. In the hypertensive patient in thiazide therapy, the recommendation is to switch to another antihypertensive medication, and losartan is the preferred option because it has a mild uricosuric effect, as shown this in the picture. And this is a drug-based effect, not a class-based effect. For patients with ischemic heart disease and cerebrovascular accident, they are against stopping the aspirin if it was prescribed in appropriate indicator. And for dyslipidemia, against switching to fenofibrate. And if the patient is indicated for statin therapy, atorvastatin is the best one between the statin because it has, again, it can lower the serum uric acid, although this is not in the recommendation, but there is a few papers that mention that. For diabetes, there is no special recommendation for diabetes, but it's wise if the patient has diabetic nephropathy to use the losartan, as we hit two diseases by one agent. Okay, we finished from the acute presentation. Now the patient who has flares, recurrent flares, what the option that we have and how do we chronically manage this patient? First of all, what the indication of urate lowering therapy? There is a nice paper that was published by our colleague, Dr. Mohammad Attiyah and Professor Hani Muallim, that showed that malpractice of 70% of prescribed allopurinol without a clear indication. So what indication of urate lowering therapy? Number one, patient with tophaceous gout. And we stress that for our junior colleagues that we have to look for the tophi in the extensor surfaces and periauricular. So those patients, you need to start urate lowering therapy. Patient with radiological evidence of gout regardless the modality. Here, as you can show, I don't know what is the pointer, yes. You can see here the bunch out appearance with overhanging edges in the X-ray, double contour sign in the ultrasound, or CT scan again showed bunch out appearance. Presence of any one of this finding is enough to start patient on urate lowering therapy. Patient with frequent gout flare, and it's defined by 2 flare or more per year. And conditionally recommended to start urate lowering therapy in patients with infrequent flare, and this is defined 1 flare per year only. It doesn't mean the first flare, it's only recurrent flare, but 1 per year. What about first flare? They conditionally recommend to start urate lowering therapy at the time of the first flare if the patient has recurrent renal stone, proving it's uric acid stone, or the patient has serum uric acid more than 9, and patient with chronic kidney disease more than stage 3 or more. And as you know, that this chronic kidney disease stage 3 defined by GFR less than 60. And they are against to start urate lowering therapy in patient with first attack without presence of these mentioned indications. What about asymptomatic hyperuricemia? They are against starting patient as asymptomatic hyperuricemia, but when we say asymptomatic hyperuricemia, it doesn't mean the patient doesn't have pain. It means the patient doesn't have a pain that results from acute gout flare. So the pain of acute gout flare, the attack of the gout is attack that lasts usually 5 days to 14 days. It's very severe, usually score 10 out of 10 at the severity scale. It's like the first big toe, sometimes the large joint, and it has all signs of inflammation, including swelling, hotness, redness, pain, and sometimes dusky color pigmentation and desquamation and peeling of the skin of the attack. But we know that the most common cause of pain in the first big toe is mechanical pain, mainly primary osteoarthritis. So not all patients with the pain in the big toe or sometimes the plantar area with high uric acid, we start them on urate lowering therapy. So now we have a patient who has the clear indication, but what option do we have as a urate lowering therapy? We have three groups: xanthine oxidase inhibitor, the uricase agent, and uricase enzyme recombinant. And because of the time and the availability in the country and FDA approved, we'll concentrate on these four medications. The allopurinol, they advise to start by low dose, 100 milligram, and titrate up. And in patients with chronic kidney disease, sometimes we use lower doses. Before starting allopurinol, they recommend to check the patient for HLA-B 5801 in patients with Southeast Asian or African American in origin. For patients allergic to allopurinol and not tolerating other xanthine oxidase inhibitor, they conditionally advise for allopurinol desensitization. And they are agonist screening for all patients for this gene. And when it comes to the clinical practice, this gene is not available in most of the hospitals, and it's very expensive. We can't overcome this situation by just advising the patient, when you use this medication, if he develops any skin reaction, just stop the medication and come to the clinic. And as you know, that the maximum dose of allopurinol is 800 milligram per day. Febuxostat, we start by 40 milligram daily. For patients with history of chronic vascular disease or patients with new chronic vascular disease, they advise to switch to other alternative urate lowering therapy. And the maximum dose is 80 to 120 milligram. 120 milligram is usually used in Europe. Uricase agent, mainly the probenecid, they use to start on 500 milligram twice daily. No need to check urinary uric acid before starting the medication, and no need for alkalinizing the urine. We just advise the patient to drink more of water and to have a good hydration to prevent uric acid renal stone. Bigluticase, I just brought the dose here for education, that 8 milligram IV twice weekly, and it is not a good option as a first-line agent. So this is the option that we have. How can we start? Before that, we'll go the treat to target strategy. We always have, when you treat a disease, you need a target. Like in diabetes, we have the hemoglobin A1C from 7 to 8. Like in rheumatoid, we have the remission and low disease activity. So what our target in gouty arthritis? So our target is serum uric acid below 6 milligram per deciliter. Or in patients with advanced disease, that patients who have tophaceous gout, we go for lower target. We start urate lowering therapy dose by the minimum dose, then we titrate up every 2 to 4 weeks. And we continue urate lowering therapy indefinitely. Regarding the choice, the first choice, they recommend to use xanthine oxidase inhibitor rather than over the probenecid. For all patients, allopurinol is the first preferable choice. Bigluticase should not be as a first-line agent, as I mentioned before. Switch to low dose and titrate up to target both xanthine oxidase and probenecid conditionally. Use of anti-inflammatory medication as a prophylaxis is recommended until the patient reaches the target, and this may take time 3 to 6 months and sometimes longer. Urate lowering therapy might be started, conditionally recommended, as might be started during the acute flare rather than waiting till the attack is resolved. If the patient fails the first xanthine oxidase, the recommendation to switch to another one rather than use uricase agent. If the patient has xanthine oxidase and uricase agent, in patients with frequent gout flare, they advise, or tophaceous gout, they advise to switch to pegloticase, and in patients with infrequent flare or gout or no tophaceous notify, against switch to pegloticase. So we moved through the acute and the target and the chronic management and the indication for urate-lowering therapy. So I will conclude that the choice of the therapy of gout flare depends upon an individual patient assessment. Not all gouty arthritis patients require urate-lowering therapy. Old is gold. Allopurinol is still our old friend, and it's the first preferred option. It is cheap and safe and available. Sorry. Okay. Prophylactic therapy to prevent flare during treatment is recommended. Target uric acid below 6. Never ever treat asymptomatic hyperuricemia. Ladies and gentlemen, thank you for your attention.